Great, thanks. Hello and welcome everyone to tonight's webinar, the fourth in a series of 5 sleep webinars brought to you by Capital Health Network and a multidisciplinary team of sleep physicians and sleep psychologists in the ACT. The final webinar in the series, the 5th webinar, will be on CPAP troubleshooting and hyperventilation and is scheduled for Tuesday, the 30th of July, so save the date. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome any other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and never has been ceded. Tonight's webinar focuses on approaches to restless leg syndrome and circadian sleep disorders. I am Dr. Leonie Harcourt, a GP education advisor at Capital Health Network. Also with me tonight are sleep physicians Dr. Saidul Ansary and Dr. Matthew Lindfield, and of course, Kunal Mohiti, the education events lead at Capital Health Network. So on to housekeeping. All participants have been muted. Please address, or if you have any questions, type them into the Q&A box, not the chat box on the Zoom panel. So the Q&A box, not the chat box. We'll have a question and answer session after both Saidul and Matthew have presented. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. With respect to CPD, please fill in the post-event evaluation that CHNs will email to you after the event, and we'll also send you a certificate of attendance so you can report 1.5 hours of educational activities to your CPD home. And before we start, just one other flag for Health Pathways. I'm sure all of you are familiar with it, but it's a free and up-to-date source of referrals and guidelines localized to the ACT area. And it has information on restless legs and other sleep conditions. The login is together, all lowercase, TOGETHER, and the password is forhealth, FORTHEALTH, all lowercase. So now the exciting part of the evening. So on to the presentations. Our first speaker tonight is Dr. Saidul Ansary. Dr. Ansary has been a consultant respiratory and sleep medicine physician at both the Canberra Hospital and Calvary Hospital since 2012. So that's over 12 years. He's a clinical lecturer at ANU and is actively involved in physician training. Has been both in public and private practice as a respiratory and sleep disorder specialist since 2012 and has a special interest in chronic cough. So over to you, Dr. Ansary. Thank you.
Thank you very much, Leonie and Kunal and the group, and good evening to everyone. I'll be talking about restless leg tonight. As a starter, when the patient is restless, the leg is still. When the patient is still, the leg is restless. Conflict of interest, none for this presentation. Of course, I see restless leg patient in my clinic. Now, some trouble with the slide moving. Sorry about that. The disease has other name WED or Willis-Eggbom disease, first described by English physician Thomas Willis about 800 years ago in 1685. Subsequently, not until 1945, the disease was clearly described by another European Swedish neurologist, Dr. Eggbom. And he described it clearly as a distinct entity. Now, Dr. Willis has rather poetic and philosophical statement about this disease. I liked his last statement, although with a pain in my heart, that if this patient were in place of the greatest torture, and you can see the young lady in the picture, her legs are moving quite frantically, repeatedly. And although this is a funny video with the wicked son is putting some CD or recorder to have fun, you can see the agony of the moving the leg. And It sort of mimics the cascading effect of restless leg can happen in someone's, can cause in someone's life. Now, since the Dr. Willis and Egbaum has described the disorder, International Restless Leg Syndrome Study Group has taken the baton, and we are grateful for their work as they have advanced the field significantly, not only revising the criteria for diagnosis, but also its investigation management and supporting the research widely worldwide. They have designed the criteria. I do sometimes use mnemonics. I'm not sure if you do. This is, of course, a sensory motor disorder with multiple symptoms, but urge is the mnemonic sometimes we use. Irresistible urge to move the legs, accompanied by uncomfortable sensation, paresthesia, which is abnormal sensations, and dysesthesia, uncomfortable sensation. It begins at rest, getting up and go, relieves the restlessness of the leg. It occurs in the evening or later part of the day, and therefore a distinct circadian pattern. Does not occur due to conditions secondary as a cause. Mainly, you delete the mimics for this condition. This is the boxed criteria by RSSG group. I won't go to the first box, but you can see there are supportive associated features, disturbed sleep, leg movement during sleep, we call it periodic leg movement, family history in particular, if the patient has early onset and positive response to dopaminergic medications. The description of symptoms can vary. Some of them report creepy, crawly, throbbing, aching, itching, pulling, electric shock-like sensation, or sometimes just to mention, doctor, I cannot describe how I feel. It's an agony. In terms of treatment or management, we do describe this as a distinct three group: intermittent, chronic, persistent, and refractory. I'll come back to it when I come to the management. If a few seconds about the PLMS or leg movement in sleep, this is actually a polysomnographic phenomenon. You may have seen some of our sleep report. Patient has mild PLMS on insignificant PLMS or severe PLMS. Basically, these are repetitive stereotype lip movement of 0.5 to 10 seconds and predominantly occurs in first half of the night. In terms of EEG, amplitude is about 8 millivolt, and there are in a sequence of 4 or more, and there are at least 5 seconds to 90 seconds apart, this strain of movement. An index of more than 15 per hour in adult, we call it significant. And this causes sleep disturbance and next day a dysfunction or tiredness, and not better explained by other disorder. Interestingly, 80% of the patient with restless leg, if you do a sleep study, you see PLMS, and about 20 to 30% of PLMS patient, if you go and ask the history, they may have clinical syndrome of restless leg. About prevalence, is quite prevalent disease, although clinically prevalent disease is lower than 10 to 12% reported in population studies. Female is affected twice the male. Europeans are more affected for some reason rather than Asian, in particular Japanese or Chinese population. Most common in pregnancy, more than 20%. Elderly gets affected more. As we have more birthdays, we risk ourselves more in restless leg. And first degree relatives about 4 to 5 times higher chance of being affected. in terms of linkage study or chromosomal study shows that several chromosomes is implicated, chromosome 2, 4, 9, 12, 14, 17, 19, and 20. I'm pretty sure if we look at the most recent study, there are another a couple of more chromosomes because we find more every year. Twin study shows that 10 out of 12 monozygotic twin pairs are having concordance in terms of restless leg. So it is the third most common sleep disorder. And while I'm talking about restless leg prevalence is 2.5%, this is actually the clinically highly relevant clinically manifested syndrome, not just mild restless leg. In terms of where these patients are, I think most of the patients are in primary care setting, and thank you for looking after them. They do come to our clinic as a sleep physician. We take the sleep history, and we certainly take restless leg history. And we highlight sometime if this is a major problem, and we treat them. Neurologists treat them quite significantly in Canberra. Psychiatrists became aware because of medication side effect, basically unmask the symptoms. Pharmacists are taking more role these days for sometime debatably other reasons, but they do. And there is a Deloitte Access Economic study done for Sleep Foundation Australia in 2021, showing that 540,000 patients or sufferers in Australia. So there's a great number, probably underdiagnosed. The causes, primary or idiopathic is, there is a cause, we don't know. Genetics play a part, and older age patient gets more affected. Secondary causes are many, but iron deficiency is at the center. Renal failure, pregnancy, diabetes, peripheral neuropathy, medication use, in particular SSRI, SNRI, dopamine blockers like metoclopramide, and do not underestimate overindulgence in coffee. This is an extensive list published in Nature's Review in 2021. I won't go through the details, but to highlight that obstructive airway disease and obstructive sleep apnea in sleep clinic population has high prevalence of restless leg, and depression is quite common with restless leg population. So these are the mimickers of the restless leg. You can see the sleep-related leg cramps, positional leg discomfort, akathisia, polyneuropathy, venous disorder. Main differential point is apart from polyneuropathy, none of them has neurological findings. And apart from polyneuropathy and restless leg, none of them has circadian pattern. Another differentiation is none of them will respond to dopaminergic agent. Pathophysiology, I wished I didn't have to put this slide on because it's hard to understand. More I read about it, more I become puzzled. And I asked Professor Winkleman in one of the presentation years ago in US, and he said, Saidul, next question, and he smiled. So pathophysiology, mainly iron dysregulation and deficiency is the center of the problem. Dopaminergic dysregulation, genetic mutation can cause more of the dopaminergic issue, altered neurotransmitter like hyperglutaminergic state or hypoadenosinergic state, and hypoxia, especially in COPD, peripheral vascular disease, that kind of patient cohort. So basically, gene and environment has interaction, and this interaction affect the expression of the host disease and phenotypes. And in terms of etiology and insight, if we know the etiology, sometimes it helps us to identify treatment target. One thing we need to tell our patient that restless leg is not a neurodegenerative condition, because the restless leg is more common in Parkinson's disease and these days patient can read and can be overwhelmed that this is a neurological degenerative disease. So this is a busy schema of pathophysiology. I won't dwell on it too long, but iron deficiency in CSF and central nervous system is at the core of the problem. Hepcidin is a polypeptide hormone which is secreted in liver and can reduce the iron transport, and somehow this is more expressed in blood-brain barrier, and iron doesn't go into the brain. These are associated with some genetic disorder, male S1 or BTBD9, which is also can cause more restless leg in if patient has this mutation and they have renal dysfunction. Hyperglutamatergic state cause hyperarousal, and if they have low iron, that can cause more disturbance, insomnia. Hypoadenisonergic state can both affect dopamine dysfunction and glutamatergic state. And dopamine dysfunction is poorly understood. However, it affects the hypothalamic region and the basal ganglia. What happens is, as a poverty in plenty situation, there may be dopamine, excessive dopamine there, but they're dysfunctional because of the receptor level issues. Here is some example of if we know the pathophysiology, we can target the treatment. If we suspect the iron deficiency, we give iron, oral or iron infusion. If there is adrenergic dysfunction, we can give dipyridamole, and that blocks the reuptake and increase the adenosine. And in terms of dopaminergic state, we can give dopamine agonist. Again, poorly understood how it works when there is plenty of dopamine. And then we can give alpha-2 delta ligands if glutamate pathway is involved. Now, investigation, restless leg is a clinical diagnosis. Investigation itself is not necessary to diagnose it. However, associated condition needs to be ruled out. Primary mode of diagnosis is restless leg rating questionnaire, but other questionnaires you can use. In particular, you can use pediatric questionnaire, which I don't use because I only see adult patients. Full blood count, iron studies, hematinic studies, renal function, thyroid function, and vitamin D is recommended in some guidelines. I don't do vitamin D. I'd rather give them if I suspect deficiency. Sleep study indicated if you suspect they have sleep apnea. I must admit the patient we see the referral predominantly for sleep apnea. So we may end up doing sleep study, but in general, we don't have to do that. Home versus lab sleep study with video is debatable as more and more home sleep study has double leg leads. But if you suspect that you may miss the diagnosis and you are doing a sleep study and patient has no issues, you can do the in-lab sleep study. Seat test or suggested immunization state, highly resource intensive. We don't do it apart from research laboratory. Nerve conduction study, I tend to do it in particular if I suspect there is a neuropathy. This is the restless leg syndrome rating scale. Up to 40 is the score. 10 question. 1 to 10 is mild. Moderate is 11 to 20, severe is 20 to 30, and if above 31 is very severe. Now about management, general consideration, we must assess other conditions, we must take history of neurological disorder, iron deficiency. Then we see if it is intermittent, chronic, or refractory. If intermittent, we intermittently use levodopa, carbidopa, or low potency opioids, short-acting opioids, especially if they have pain disorder. Benzodiazepine if they have insomnia. Chronic persistent restless leg, we don't use dopamine, we use alpha to delta ligand, which is gabapentin or pregabalin. Refractory restless leg, we consider combination therapy or opioid therapy. Now, non-pharmacological treatment is important. Iron, caffeine with caffeine minimization, alcohol minimization, cessation of smoking or reduction of smoking, stopping or reducing the dose of the drugs may be implicated. You can keep them busy, give some activity, video games, which I don't suggest. Crossword is not as harmful. Consider conditions or factors might exhibit symptoms like sleep apnea, shift work, or sleep restriction. Now, assessment of other sleep disorder, I'll say one thing here, insomnia is highly prevalent and we shouldn't miss it, but otherwise anxiety, depression, sleep apnea, we need to look for. Now, this is the symptom-based classification or subclassification I alluded initially. If someone has intermittent symptom less than twice per week or few times in life, we call intermittent. Chronic persistent, if symptom happens more than twice per week, at least for last 12 months, and refractory is we treat with first-line agent, and either it doesn't work or a drug causing side effect or causing augmentation. Now, 4 classes of drugs: dopaminergic agent, gabapentin or pregabalin, opioids, ion, cannabis. What's the space? There is 1 or 2 small studies. There is no randomized control trial as yet, but they're on the way. Tonic motor activation is a device which is FDA approved only end of the last year. None of my restless patient is as happy as she's sitting there, but she's a model, of course. Now, ion treatment, I would highlight that some of the patient may have normal ferritin up to 75 to 100, but if they have severe symptom, we still give ion, and even if their transferrin saturation is 40 above 40, we still give ion. In this scenario, we have to give intravenous ion, as oral ion will not be absorbed because of the ion transport mechanism. And if symptom doesn't improve after first infusion, you can give another one as long as ferritin you maintain below 300. There's a placebo-controlled study of 110 patients, small number, but you can see the response to ion is quite dramatic at 12 weeks. Now, one slide about this pramipixole. For a lifelong disorder, the study is only 12 weeks. So although it's effective and initially quite enthusiasm, but subsequently we know that this drug causes significant side effect. Now, augmentation is one of the complication and side effect. Basically, you give the medication for long enough and restless leg symptom is starting earlier than it would be started otherwise. Now, one of the sleep meeting I went to, this was the slide presented. Increasing concern in RLS community that these dopaminergic agents are addictive. They create a need for medication at times that were unaffected beforehand, like someone having restless at 6 p.m. but now having 4 p.m. Increasing dose is required and worsening symptom or withdrawal and rebound. So there we go, augmentation. So these are the criteria. If happens early, if needing higher dose, then you suspect augmentation. And if augmentation happens, you need to treat it. So some augmentation can go for just a little bit early, which is easy to treat, but severe augmentation more than 8 or 12 hours is really difficult to manage. Dopaminergic agent has other side effects, you name it, sleepiness, nausea, vomiting, and augmentation. Impulse control disorder. Now, prevalence of this impulse control disorder is quite high, 9% for compulsive shopping, 5% for pathologic gambling, 11% for compulsive eating, and overall 15 to 70% of this impulse control disorder. So we cannot neglect it. And therefore, American Association of Sleep Medicine has come with a statement that dopaminergic agents are no longer first-line agent for chronic restless leg. That is in 2016. Now, this is intermittent restless leg. I alluded before. We use intermittent levodopa if it's insomnia, benzodiazepine, low potency opioid, which I tend not to use for intermittent restless leg. These are the doses I just mentioned because I understand this will be on YouTube. Chronic persistent restless leg, as I mentioned, gabapentin or pregabalin, unless contraindicated because of severe obesity, poorly controlled weight management, severe depression, or patient has respiratory failure. Again, the doses and details are here. I won't go in details. This will be on YouTube. Now, ropinirole is a non-ergot medication. Initially, there was enthusiasm that it doesn't cause augmentation, but subsequent study proven that this is also can cause augmentation. Rotigotone pass is less of a problem because it's a pass. It goes for a number of hours unless you remove the pass, which is an option for severe cases of augmentation or refractory cases, but unfortunately, this is not approved in this country for this indication. This is the comparison table for alpha to delta ligands presented in Mayo Clinic the proceedings. Important point here is gabapentin maximum blood level is 2 hours and pregabalin 1.5 hours. So therefore, dosing has to be given in a way that it's sort of fallen within an hour of patient symptom onset, and every patient is different. And this is the maximum doses, as you can see. Again, dopamine agonist, most important point from this slide, the maximum blood level so that you can target giving the pramipixole probably an hour so that of the symptom onset, ropinirole, that kind of time. And one other important point is FDA approved maximum dose of pramipixole is 500 microgram, not 750 we do in Australia. In fact, I never use more than 500 microgram in my practice. Refractory restless leg, if you face them, you go back to the drawing board, see why it's refractory, is the iron store abnormal, is there any other exacerbating factor, are they restricting sleep? Consider combination therapy, and if nothing works, opioid is the way to go. And this is the box. I won't go in details. Apology for the slide movement. This is the dose chart for the restless leg in recent IRLS group and Mayo Clinic. And I normally don't use more than 15 to start with as a codeine. A patient is elderly, but you can use up to 60 to 80 milligram. Oxycodone up to 30 milligram, methadone, which I usually don't use. I tend to get my psychiatric colleague or pain colleague to help me. Buprenorphine you can use. And pregnancy-related RLS, main important point is in first or second trimester, we tend to avoid medication apart from iron, and you need to involve the obstetrician. In childhood, again, I don't treat them, but iron is important. If they're restricting sleep or there is other disorder, you need to make sure we suss it out. Mainstay of the treatment is iron, comorbid disorder being treated, and then low dose pregabalin or gabapentin. Now, augmentation, as I mentioned, is a problem, and I think we all may have faced this problem in our clinical practice. And we need to make sure that we look for it. And the mechanism is usually upregulation of D1 dopa receptor and downregulation of inhibitory D3 receptors. Now, if you see the augmentation, if clinically fulfilled augmentation, you can keep the same daily dose if they're mild augmentation, or you can split the dose, or you can switch them to a second agent, different agent. If severe augmentation, what we need to do is add alpha to delta calcium ligand, channel ligand, and then slowly withdraw the dopaminergic agent over 10 days, but usually it may take longer. Never stop the drug dopaminergic agent instantly, because patient will have terrible time. If this strategy fails, you can try monotherapy of opioid. This is the IRLSG group's chart, which is busy, but highlighted the cost titration, like you do not stop the medication, initial medication, you do slowly titrate one drug and withdraw the other drug. The guidance for opioid treatment: if someone has RLS symptom 4 hours per day, you use short-acting drug. 6 to 10 hours, you use OxyContin. If more than 10 hours, you tend to use methadone. And this is the dose again. Now, quickly a case, 57-year-old female seen in one of our clinic in Sydney Hospital. I practiced years ago. Junior register saw the patient. I agreed that yes, sleep study is needed. Up we go. She had depression. The drug was paroxetine, may cause more leg movement. Epworth sleepiness score was borderline. And then second time she came with the sleep study. What we saw is all this periodic leg movement, and it sort of opened my eyes and said, what the heck is happening? And her restless leg rating score was 21, moderate. We did the iron study. She has low ferritin. We gave intravenous iron. She came second appointment, third appointment, she didn't even bother to come. So that's the history of iron. And you can see the sleep study data. Only a HSA of 6, no sleep apnea almost, PLMS index, one of the highest I've seen, 78 per hour. So iron has fixed our problem. This is a quick snapshot from RSCP website. Basically, you take the history, you make sure there's neurological or other disorder. Yes, there's intermittent. Go for low dose levodopa, dopamine agonist, benzodiazepine if they have insomnia. Persistent RLS, you go alpha to delta ligands, maybe dopamine agonist if there is contraindication. Refractory restless leg, you combine the treatment, you check the iron, you check the other disorder. If nothing works, opioid, and hopefully the stimulator I showed you. Now, management takeaways briefly: unless contraindicated, alpha 2 delta ligand, i.e. gabapentin pregabalin group is the way to go. Patient selection is important. If they have contraindication, obesity, severe depression, we try low dose of pregabalin. We may not use it. We may use the dopaminergic agent. Dopaminergic agent is associated with augmentation, and long term, we need to monitor for gambling, for impulse control, and other disorder. If needing dopamine agonist, we keep the lowest dose possible. 500 microgram would be the dose, although in Australia, 750. We do not forget iron. obstructive sleep apnea, insomnia, and sleep restriction with all the emails and distraction of WhatsApp and whatnot we have in our life. For us specialists, working with the patient general practitioner is a blessing, and you may have seen many of my later. With your permission, her restless leg or sleep disorder has improved, and I would like to request you take over the care. Thank you very much. I would invite question towards the end of the our webinar today.
Thank you very much, Saidul. That was fantastic. Some really kind of clear take-home messages that we can implement as GPs. So moving on to our second speaker for the night, and that's Dr. Matthew Lindfield. Dr. Lindfield is a third-year advanced trainee in respiratory and sleep medicine at the Canberra Hospital. He has a special interest in interventional pulmonology, lung cancer, thoracic imaging, sleep medicine, and improving health disparities in regional and remote communities, which is a very admirable interest. So thank you very much, Matthew, and over to you.
Yeah, g'day. Can everyone see my slides and hear me? I'm assuming so.
We can hear you. Slides are about to come up, I hope.
Okay, let me just give me 1 sec. Window.
Yeah, we haven't got the presentation mode. We've still got the notes mode. We've got your screen though.
All right, so let me just try and do that what we did before. So share entire screen.
Yeah.
Share. And then how's that?
That's perfect. Thank you.
No worries. I'm sorry I can't my camera isn't working at the moment, so you're just gonna have to look at the slides. So I've been asked to talk about circadian rhythm disturbances. What we're going to go over is circadian rhythm and I guess melatonin theory, as they're so closely linked, as well as conditions such as delayed sleep phase syndrome, advanced sleep phase syndrome, which is basically the opposite, shift work sleep disorder. Someone's flicking through my slides. Jet lag, non-24-hour sleep-wake disorder. Be quite quick with this one, as literally a single slide or two, because it's pretty rare. We're going to try and focus on management. So the resources I used were predominantly Sleep Medicine Pearls, the third edition by Richard Barry and May Wegner, as well as Up to Date and ETG, which is good resources for all things medicine on those following topics. And I believe the ETG was last published March 2021. And I've got no conflicts of interest. So this is a hypnogram that hopefully a lot of you would have seen from our sleep studies that we send out. I'm not sure if you can see my cursor, but this is quite like a normal hypnogram, more or less, with the green being N2 sleep, blue being N3, the yellow being N1, and then this up here being REM sleep. And at the start of the night, you can more or less see consolidated sleep, so it's not jumping between phases. The second half of the night, you can definitely see some what we call sleep fragmentation, and as expected, REM sleep gets a bit prolonged at the second half of the night. So with delayed sleep phase syndrome, as you can see from the hypnogram, there's hardly any sleep. And this is one of the problems that we have trying to do sleep studies on people who stay up the whole night, is that they hardly ever sleep. We do capture a bit of data on this gentleman anyway. So he went into N2 sleep here. You can see corresponding drop in his oxygen saturation. So he could be having apneic events. The arousal index is increased, and he had some movement, some PLMs, as Dr. Ansary has just talked about, and obviously respiratory events in the form of hypopneas. But there's not much you can really take from this study, because I think it was only 20-ish minutes of sleep in total. But there has been times, I guess, when we've been doing sleep consults where we haven't ordered a sleep study just because the patient doesn't sleep throughout the day and the Canberra hospitals, throughout the night, and the Canberra hospital's too noisy. So in terms of circadian rhythm theory, so Latin for about a day, and it's a timekeeping system which influences consolidation of sleep and sleep-wake episodes. The intrinsic circadian time oscillates for a period longer than 24 hours, approximately 24.2 hours. And this 0.2 becomes more important when I go on to discuss 24-hour sleep-wake disorder. The 0.2 becomes pretty relevant. So the circadian pacemaker cells in mammals are in the suprachiasmatic nucleus, and these modulate many physiological processes, including body temperature. And a lot of the studies into circadian rhythm actually use body temperature as a marker of, where they are up to in the circadian rhythm. Obviously, melatonin secretion from the pineal gland. And a properly aligned circadian rhythm maintains low alertness during the night, and particularly in the later half of the night, and promotes sleep consolidation. So those nice solid blocks of N2, N3 you saw on the hypnogram. The most powerful external factors that influence circadian rhythm is light, with meals, exercise, and other social interactions also being factors. The retinal circadian photoreceptors are maximally sensitive to blue light, and blue light suppresses melatonin and a decrease in the core body temperature. So in terms of pathophysiology, I've kept this quite simple. Basically, you can have issues with, so I'm not sure, is someone controlling my slides? But if it's flicking, it's not me. I'm telling everyone that. But basically, intrinsic abnormalities in the circadian rhythms are rare. So disruption of neuronal circuits, basically. So if you have damage to the suprachiasmatic nucleus, the pineal glands, very relevant is the eyes. So glaucoma. So in terms of photoreceptors, just not getting at the photons of light to the receptors that they need to hit. And then the extrinsic, and usually where we target our management, the behavioral abnormalities are usually related to inappropriate light exposure. These are reversible. Air travel, shift work, so the social interactions late at night. And when you have a dyssynchrony between the internal circadian time system and the desired sleep-wake time, it can result in these sleep-wake disorders. So, blue light, as I just mentioned, it does suppress melatonin secretion. And this is the most common story that we get from patients is, I usually ask them, what time are you in bed? Then what time are you asleep? And what are you doing immediately before going to bed? And most of them are with social media these days, playing on their phones, which will suppress their natural melatonin production. And I guess if they're spending a lot of time in bed before going to sleep, they reduce their what we call sleep efficiency, and that's not good for sleep either. So expert consensus recommends that during the 3 hours prior to bedtime, light exposure should be limited. Melatonin. So endogenous melatonin begins to increase approximately 2 hours before habitual sleep onset if the patient's using dim light. Melatonin decreases back to undetectable levels in the morning, and core temperatures then begin to rise in association with this. 5 milligrams of exogenous melatonin, so in the form of a drug, approximates the endogenous dose. So taking melatonin at night when it's dark is likely less effective, as endogenous melatonin is high and the receptors are saturated. Melatonin half-life is 30 to 45 minutes. And I guess one thing to consider is that there's often confusion around exogenous melatonin, particularly from patients, but most likely also from clinicians, is that there's two different goals of melatonin. So there's whether you're trying to cause a phase shift, and you can use low doses, and it's usually immediate release, so doses up to 0.5 milligrams. But it's important to note that at these doses, there is no hypnotic effect. So if patients are taking a dose and they're expecting to feel sleepy, it'll often lead to them discontinuing it, because it's not the desired outcome like they would expect with hypnotics. High doses such as 5 to 10 milligrams do have a hypnotic effect, but obviously there's a short half-life, so it's not particularly good for sleep maintenance insomnia, or keeping them asleep. And also, if you take it at night when endogenous melatonin is already high, then it may also have less effect. So the phase shifting effect of exogenous melatonin is minimal during dark periods, and I've just said that. Patients do not typically understand this. Yep, I've said that. Confounding this for immediate release melatonin, practitioners need to either go to compounding pharmacies or apply through the special access scheme. So delayed sleep phase syndrome. So this is actigraphy. So act meaning action, and then graphy on a graph. So all the bars that you see is where the patient's moving, and then you can see that there's absence of moving at around 4 a.m. There's some periods where there's a solid red bar. I think this table's from Up to Date, so I give them credit. And yeah, the solid red bars where they've fallen asleep throughout the day. So delayed sleep phase syndrome is the most common circadian rhythm, approximately 5% of teenagers. The bedtime is typically 2 or more hours delayed relative to conventional acceptable times. Results in chronic sleep restriction, impaired daytime function, increased risk of depression. Suspected in patients who have difficulty falling asleep at night and difficulty waking up in the morning. Confirmed by the presence of a consistent circadian phase delay on actigraphy. You would use PSG or polysomnography to exclude comorbid conditions. And delayed sleep phase disorder is often confused with insomnia, with the difference being that someone with delayed sleep phase syndrome, when they're introduced to a normal circadian rhythm, their total sleep time typically normalizes, and you don't observe hypersomnolence the next day, as potentially measured on an Epworth sleepiness scale, or they just tell you they're less tired. If given an opportunity, those with delayed sleep phase will not be able to sleep at ignore that bit, that was incorrect. Management. So non-farm is the most important. So try to address the external behavioral factors in circadian rhythm theory. So minimize or eliminate caffeine, nicotine, alcohol, avoid daytime naps, increase their sleep efficiency. So the actual time that they spend when they're in bed. Refrain from stimulating activities before the desired behavior. So approximately 4 hours, you often find people are playing netball or touch football at 9 p.m. at night, and then try and get to sleep at 10. With exercise, you get a sympathetic response and more alert. Avoid sleeping in on weekends, more than 30 minutes past the weekday wake-up time. Obviously, very important, avoid exposure to blue lights at night. Introduce sunlight early in the morning or on waking. So some strategies is to try and shift their bedtime and wake up time by 15 to 30 minutes each day, closer to what a natural circadian rhythm would look like. Reduce the exposure to light in the afternoon and evening. So, wearing sunglasses at night. Seeking bright light whether natural or artificial, for at least 30 minutes upon waking is important too. Timed melatonin, so noting the two different goals of melatonin, so whether it's a phase shift or a hypnotic effect. If it's a phase shifting attempt, you may need to warn the patient that they may not feel particularly sleepy, and to give it some time. Use of hypnotics to help achieve earlier bedtime is discouraged in this condition. Pharmacological management. So as I mentioned, this is from ETG. Small doses, 0.5 to 5, 1 hour before desired bedtime, arguably earlier when there's, because that, your endogenous melatonin will be starting to creep up. Review in 4 weeks, and the optimal duration of therapy is unknown. And now the opposite, advanced sleep phase syndromes. This is in a condition where people have a sleep schedule that's consistently running earlier than desired. So patient will fall asleep at, say, 8 p.m. and wake up at 3 a.m. This may be secondary to normal aging or pathological phase advances. So patients often force themselves to try and stay awake in the evening, but then they continue to wake up at the same time, and then over time they accumulate a sleep debt and excessive daytime sleepiness, so it's a futile attempt. It's important to exclude comorbid diagnoses, such as chronic insomnia. Usually with insomnia, if the patients are given an opportunity to sleep, they cannot, whereas if it's advanced sleep phase syndrome, they will sleep, but then cannot when they wake up at the, in the middle of the night. Obviously exclude other causes of waking up in the middle of the night. So when you have obstructive sleep apnea, you have EEG arousals, and potentially you could wake up from that arousal and then not sleep just because you got a little bit of sleep just prior. Mood disorders such as depression should also be considered. Management depends if the patient's overly bothered by the sleep schedule, but again, it's essentially the opposite. Bright lights in the evening. Timed melatonin might theoretically help cause a circadian phase delay, but it's not been studied. And the use of melatonin or other hypnotics with symptom of early morning awakening is discouraged due to potential daytime sedation from these agents. Jet lag. So diagnosis is insomnia or excessive daytime sleepiness associated with a reduced total sleep time and coinciding with at least 2 time zones crossed, and they will have impaired daytime function that begins within 2 days of travel without another explanation of this sleepiness. It's made worse by crossing multiple time zones, eastward travel, and interestingly, eastward travel, it's because it requires a phase advance for adaptation to the new zone, which is easier to do, whereas westward travel requires a phase delay, which is harder. So i.e. it's easier to stay awake longer than it is to go to bed earlier. Fatigue is caused by in-flight conditions, so hypoxia, dehydration, low pressure cabins, and sleep deprivation obviously reduces the total sleep time, and then they will be sleepy. That can make jet lag worse. Management. Non-pharmacological strategic approaches would be before travel. You can try and shift shift their bedtime to that of the destination, like closer to that of the destination every 30 minutes a day. And you can take time melatonin 1 hour before you would typically go to sleep in your destination country. In the flight, try and keep active during daytime hours, what would be the daytime hours at your desired destination, and sleep when it's the normal sleep time of the destination. On arrival, maximize sunlight during the day. Caffeinated beverages can help. Delay the sleep until it's nighttime in that country, but you can take up to 30-minute naps, and then remain in the dark during that country's nighttime, even if unable to sleep at that destination, when you're at that destination. Farm, as I said, melatonin, and then they continue for up to 3 subsequent nights. Other drugs, such as the Z drugs, ETG has ranked them in terms of quality and quantity of data to support their use. Obviously, if they have Z drugs, try and take a history regarding parasomnias or abnormal behaviors before you prescribe, and consider for longer acting hypnotics such as benzodiazepines, the risk of immobility and increased risk of DVT in individual patients. Shift workers' sleep disorder, increasingly recognized as a risk factor for a variety of health outcomes, including cancer, metabolic syndrome, weight gain, obesity, cardiovascular disease, and pregnancy complications. Both sleep duration and sleep quality are commonly affected in shift workers, and they generally report 30 to 60 minutes less sleep compared to daytime workers. Diagnostic criteria in terms of the International Classification of Sleep Disorders, report of insomnia, reduction in total sleep time associated with recurring work that overlaps with usual time for sleep for at least 3 months, and the symptoms cause a clinical significant distress or impairment. Sleep logs and again actigraphy monitoring is helpful. And then the sleep disorder is not better explained by another current sleep disorder, such as obstructive sleep apnea or medical or neurological disorder. Treatment, so the non-pharmacological management, obviously, if they can change profession, I know that's a very simple suggestion, but if they can, that would be good. Improve sleep hygiene, so correct environments at home when they're trying to sleep. Obviously, remove as much light and noise as possible. Hypnotics such as short-acting benzodiazepine receptors or orexin receptor antagonists can be used to promote daytime sleep. There could be carryover sedation into the night shift. Limited studies show that they may improve sleep time by 30 to 60 minutes. Exogenous melatonin, so a meta-analysis of 7 small randomized controlled trials versus placebo in 263 patients found that 1 to 3 milligrams improves their total sleep time. However, the quality evidence was quite limited due to the small sizes. It shouldn't be more than 1 to 3 milligram doses and taken, they say, 30 minutes prior to the desired onset of sleep. And then non-24 hour sleep-wake disorder. As mentioned, the circadian rhythm is controlled by the suprachiasmatic nucleus, slightly longer than 24 hours, so 24.2 hours. So individuals with non-24 hour sleep-wake disorder and unable to maintain appropriate alignment with the 24-hour environment, as they have no external factors such as light to entrap the circadian rhythm. So each day their sleep pattern drifts, typically later with respect to the external time. And it primarily affects those who are blind, but has been recognized rarely in sighted individuals. And they said in a study of 127 blind individuals, 63% of those without light perception had this disorder, while only 31 of those with intact light perception had this disorder. So it's probably more common than what people appreciate in patients who are blind. And then you've got to, because it's only 0.2 of an hour, you've got to take a sleep history over many weeks, because there will be periods where their sleep system and circadian rhythm time perfectly with the normal circadian rhythm, so day and night, but then over time, it'll slowly drift later than earlier, and sleep logs and actigraphy can help with that. In blind individuals, the treatment is timed melatonin. In sighted individuals, it's melatonin with behavioral strategies and appropriate exposures to lights. And you got to remember that circadian adjustments to achieve this synchronization or entrapment can take up to 2.5 months, depending on the individual. Thank you.
That's great. Thank you very much, Matthew. So we'll just move on to questions and answers now. So if anyone has any questions, please type them into the Q&A box and we'll read them out to the presenters. I might just start with a question for you, Saidul. Is there any kind of understanding why restless legs affects legs, and does it ever affect arms as well?
Oh, look, I think it happens more in arms when we see augmentation due to receptor being muddled, like D3 inhibitory receptors are downregulated because of the treatment, and excitatory D1 receptor upregulated and cause movement disorder. Apart from that, there are subgroup of patient who has severe form of disease, and they have their upper limb is affected. It's poorly understood why some of them just get leg or mostly get leg. There are theories that legs are, if you agree, that more congested, more venous congestion, because our body is a body of fluid.
Yeah.
Venous congestion, varicose veins, poor circulation is more common in leg. I suppose legs are further away from heart, if you agree. So, but it's poorly understood. Yeah.
Yeah. Yeah, interesting. Matthew, I might just ask a question about melatonin. So, as you know, melatonin is quite commonly prescribed by GPs. So we hear about a lot of kind of side effects about when it hasn't worked. Or unpleasant side effects. So two that we hear about is nightmares, and the other one is people feeling, even on a low dose, overly sedated in the morning, that takes a couple of hours to clear up in the morning, even if they've taken it early at night. Are you able to comment on any of those side effects?
Well, I guess, and I'm happy for Dr. Ansary to jump in whenever if he feels appropriate, but melatonin in terms of oversedation is quite rare, and it's probably due to another pathology that could be occurring, or potentially even I guess like a placebo type effect, just given because the half-life is so short. Obviously, with the longer acting melatonins, that it may be more applicable. But yeah, I would, if someone was particularly experiencing hypersomnolence through the day, I would exclude everything else before I label it related to their melatonin. And if you are able to get some immediate release melatonin, potentially a trial of that may be beneficial. And sorry, I missed the first
question. So the first one was just about people having nightmares. I think it's children. So sometimes, as you're probably aware, children are put on melatonin, especially with neurodiversity, and sometimes they experience nightmares more when on the nights they take the melatonin, and not so much on the nights they don't take the melatonin. Is that a well-known side effect of melatonin?
It's not. So I haven't treated children, but I haven't observed it in adults or complaining of nightmares with melatonin. Usually with nightmare disorder, it's more likely to occur in REM sleep, and I don't believe melatonin affects REM sleep. Dr. Ansary, do you have any
Yeah, look,
comments on that?
it's interesting observation in some patient, again, poorly understood. I suppose if sleep is promoted and they go into what we call slow wave sleep because of some of the sleep issues are sorted out, there is a night terror disorder which can happen in slow wave sleep rather than REM sleep, which can be sometime affected by melatonin. But this is a small point. There may be, I mean, if you look at night terrors or nightmares, I mean, it's hard to differentiate from patient history if it is during slow wave sleep or because kids are, if it happens more in first half of the night, it's more of night terrors. If second half of the night, more REM sleep, which could be nightmares in REM sleep, So patient in slow wave sleep, if they are difficult to arouse and they are confused, it's sort of more of deep sleep or slow wave sleep, which could be implicated by melatonin,
Because
especially.
melatonin does help with sleep consolidation.
Yeah.
So theoretically, potentially, if they, have better consolidation, like what you saw on my, I see. If I'm still sharing my screen, I can just go up to the hypnogram. This is slow wave sleep here. This solid blue line and
We haven't
melatonin.
got your screen, sorry. But yeah,
Ah,
I remember the screen and you
yeah,
had the
yeah.
Yep. And last of all, I'll just might ask one more question, and this goes out for all the middle-aged females who are in the audience tonight. What about MHT, so menopausal hormonal therapy and helping with sleep? So is that something that you consider? It's very common to develop insomnia around the menopause.
Dr. Ansary.
Look, insomnia has 50 shades of gray, like any disorder. It is, if insomnia is associated with perimenopausal syndrome, some of them actually can have more symptoms of restless sleep for some reason we don't understand. And there is a role for hormonal manipulation, but I think it's mainly targeting the symptom if this symptom is clinically causing insomnia. I obviously don't treat this patient. If I'm facing them, I gently ask who was their gynecologist and I call them and I say, look, what do you think? And
Yeah.
because it's hard to monitor and I do worry about the side effect and longitudinal side effect,
Yep.
One patient had DVT, I remember.
Yeah.
I don't know how much I can relate this DVT to this hormonal manipulation,
Yep.
I tend to avoid them, yeah.
Yep.
And I suppose it would probably, if it was a sleep insomnia maintenance issue, then I guess a detailed history as to what's actually woken them up, and if there's any symptoms of menopause that's preventing people from going back to sleep, potentially treating that first and then escalating treatment from there to
Yep.
hormone
Yeah,
replacement.
important point, Matt, if I can jump in for 10 seconds. Some of them we don't understand or we poorly understood this phenomenon. They develop isolated REM-based sleep apnea, which actually cause sleep fragmentation second half of the night. And unless we take detailed history when they wake up and we sort of convince them to have a sleep study, we see beautifully they started waking up the second half of the night with REM sleep.
Sometimes I think they think that with the loss of estrogen, and that causes a loss of collagen integrity, and so that could be partly affecting the throat and the tongue, and so supplementing their estrogen, well, doing often combined HRT can help with that as well. Anyway, okay. So thank you both very much. Both very interesting and some really kind of good take-home messages for us. Always check iron and try and cut back on caffeine, I think would be the primary one for restless legs, and then move on to your gabapentins and try not to do dopamine agonists. Is that right, Dr.
Yeah,
Saidul?
look,
Yeah.
dopamine agonist is a great drug and it works. But if we keep escalating the dose because that augmentation or earlier symptom or patient developing tolerance, we end up having a situation that we can only give so much dopamine agonist and we end up having impulse control and depression and other issues. So I think regular follow-up, getting them off caffeine, blue screen, sleep restriction,
Yep.
and iron, all these things are important rather than keep pushing the pramipixole, you know? Yeah.
Yep. And thank you very much, Matthew. So some really interesting things about how to manage jet lag and advanced sleep disorder, delayed sleep disorder, and interesting facts about people without sight. I didn't realize that there was such a clear difference with a 24-hour or 24.2-hour sleep cycle. So we'll wind it up there, and the next sleep webinar, as I mentioned before, is going to be on the Tuesday, the 30th of July, and it'll be on CPAP troubleshooting and hypoventilation, and that will be with Dr. Carol Huang and Dr. Deborah Inman. We've had a fabulous set of sleep webinars, so after the last one, we will have 5 altogether, and they're all on the Capital Health Network YouTube page. So we'll also send out evaluation surveys for this webinar, the Restless Legs and Circadian Rhythm webinar. Please fill them in. We'll also send you a certificate of attendance, and you're able to self-report 1.5 hours of educational activity to your CPD home. So thank you very much, everyone, for attending tonight.
And I should say special thanks to Matt for joining me. Otherwise, I would have been solo today.
Thank you both. Thanks. Okay. See you. Good night.
No worries. Thanks.